Now we'll talk about palliative and end-of-life care. Palliative care includes the goals of enhancing quality of life for the patient and family, optimizing function and helping with decision making and providing opportunities for personal growth. Its focus is to improve the quality of life of patients and families who face a life-threatening illness. It's often initiated when a life-threatening illness is diagnosed, and it includes hospice and end-of-life care, but it's broader than that. There are 6 major skills of palliative care: communication, decision-making, management of complications of treatment and disease, symptom control, psychosocial care of the patient and family, and end-of-life care. Symptom management refers to the prevention or treatment of symptoms or side effects associated with the disease or the treatment of the disease. And comfort care is often used interchangeably with symptom management. The nurse works with the patient and family to identify symptoms like dyspnea, nausea, insomnia, weakness. Patients and family members are taught about the disease and its symptoms, as well as any of the side effects that might be associated with treatment. The symptom relief will focus on depression, anxiety, delirium, and cognitive impairment. The psychosocial aspects of care also involve assessing the patient's caregiving needs as well as the family's potential to provide care. Alternative therapies include relaxation, music, and guided imagery. And when it's appropriate, patients and caregivers should be referred to other healthcare professionals such as psychologists or social workers or psychiatrists for help with the relief of these symptoms. The family conference is one way of creating an environment for communication for the patient and the family members. Your social assessment should be of the family relationships, the patterns of communication, the goals of patient and the caregiver, and there should be a mutually agreed upon plan of care. Hospice is a concept of care that provides multidisciplinary care at the end of life with an emphasis on symptom management, advanced care planning, spiritual care, and family support, which includes bereavement. Hospice generally follows the family for a year after the patient expires. There are about 3,300 hospice programs in the United States. Some of them are hospital-based, some of them are home health agency-based, some are freestanding, and some are community-based. Generally, the emphasis is on palliative rather than curative care. In general, though, hospice care is provided in the home, with inpatient care reserved either for acute pain management or respite so that the family or caregiver can have a break. Home care is provided on a part-time, intermittent, on-call, regularly scheduled, or continuous basis. It's quite individualized. Hospice is medically supervised, and the hospice nurse is an integral part of hospice care. The nurses work collaboratively with hospice physicians, pharmacists, dietitians, physical therapists, social workers, CNAs, clergy, volunteers, and they provide care and support to the family and the patient. Starting hospice is often a difficult decision for patients because they may see it as giving up. They may see it as very finite and subsequently might wait until very close to their ultimate death to begin to participate. Sometimes the physician sees the patient decline as a personal failure, but often it's patients or families who just aren't ready, and they may see it as giving up. It is noted that African Americans may underutilize hospice because of a lack of awareness of the hospice services. Sometimes a desire to continue with potentially curative therapies, and concerns that there's not any hospice workers of their ethnic minority. Hospice has two admission criteria. The patient has to want hospice services, and the physician must attest to the fact that the patient has 6 months or less to live. A physician can recertify that, people can be in hospice if they don't die, but generally it's an acknowledgement on the part of the physician and the patient that death is likely to occur in the next 6 months. Although I have seen people graduate from hospice and then be readmitted later. One of the benefits of hospice is bereavement counseling and grief support, and they stay with the family for a year after the patient's death. Today, as a result of the graying of America and the increasing number of people with chronic diseases, terminal illness, and dying has received greater attention. Right now, 75% of Americans live past the age of 65, and 83% of Americans die while they're covered by Medicare. Most individuals have a long period of serious illness before dying, with the onset months or years before death. So, for example, about half of all patients diagnosed with cancer will die from their disease within a few years. Nurses spend more time with patients near the end of life than any other healthcare professional. The goals of end-of-life care include providing comfort and supportive care during the dying process to improve quality for the remaining time that the person has, and to help make sure that the patient has a dignified death. This table illustrates the stages of grieving as defined by Elizabeth Kubler-Ross in 1969, Martocchio in 1985, and Rando in 1993. Prolonged grief disorders can include symptoms such as recurrent distressing emotions and intrusive thoughts related to the loss of a loved one, severe pangs of emotion, and self-neglect. And it's estimated that 1 in 5 bereaved individuals experience a complicated or prolonged grief. Prolonged grief disorder is defined as prolonged or intense mourning with denial of loss for greater than 6 months. Absent grief is defined as the person appears to be coping and carrying on as if nothing has happened. Adaptive grief is the healthy response, and it's what we'd like to see. Um, and the goals for the grief process are resolving of emotions, reflecting on the dying person, expressing feelings of loss and sadness, and valuing what's been shared with the loved one. People who are legally competent may choose organ donation, and any part or the entire body may be donated. The decision to donate organs or to provide anatomical gifts can be made by a person before their death, and the decision to donate organs can be made by the immediate family members after death. Other ethical issues would be the patient should have advanced directives. They should be detailed. Quite often they are not detailed enough to really direct care at the end of life. And then also in that area, resuscitation and what is desired and what is not. Advanced directives are written statements of a person's wishes regarding medical care. We also have called this a living will, and advanced care planning is focused on anticipating the challenges that the patient and family will face because of the illness or medical treatment. Many states have replaced the idea of a living will with natural death acts, which in many of these acts are specific aspects related to the individual's wishes, directives to physicians, durable power of attorney for health care, and medical power of attorney may be included in natural death acts. A physician's order should be written to include the information concerning the patient's or family's wishes for the use of CPR. There are several different types of CPR decisions that can be made. Complete and total heroic measures, which might include CPR, drugs, mechanical ventilation, is also referred to as a full code. Chemical code involves the use of drugs without CPR. No code or DNR order allows the person to die with comfort measures only and without the interference of technology. Some states have implemented a form called out-of-hospital DNR for use by terminally ill patients who wish to have no heroic measures used to prolong their life after they leave the acute care facility. And sometimes in acute care facilities or perhaps long-term care, you'll see the abbreviation AND, which is used instead of DNR as a more positive statement, which is allow natural death. Common legal documents include durable power of attorney for health care, and this lists the person that's able to make decisions should the patient become unable to make informed decisions for themselves. It does not take effect until the person cannot make decisions for themselves. Financial power of attorney is not durable power of attorney for health care. They are two different things, so when the person comes to you insisting that they have power of attorney, it's important to distinguish what kind of power of attorney they actually do have, and you can ask them to bring you the documents. A living will actually has instructions in lay terms about future medical care and treatments and death without heroic or extraordinary measures, and it's generally enacted when a patient is unable to communicate. Again, medical power of attorney lists the persons who are able to make healthcare decisions when the patient is unable to do that. The ethical issues that come into play include the principle of beneficence, which involves adequate pain relief and particularly for patients with terminal illness. There's no worry about addiction. The principle of non-maleficence is prevention or reduction of harm, providing adequate pain control, and sometimes the secondary effect of adequate pain control may be a hastening of death. So, for example, if you are giving a patient with end-stage lung disease morphine to ease their breathing, and it helps them die sooner, that is perfectly fine. You're not going to make them better. It really doesn't make them worse. So hastening death as a secondary effect of adequate pain or anxiety control is justified ethically. Euthanasia is the deliberate act of hastening death, and in our society that is not morally acceptable, and partly it's because people have some base instincts and they could be euthanizing someone to get access to their valuables or their belongings and so forth. The frequency of nursing assessment depends on the patient's stability, but you're not going to do anything for these patients, so it's generally done at 8-hour intervals, but sometimes that's not even warranted. It's just a documentation that you were there and that assessment occurred. Neurologic assessment is important as the patient gets closer to death. Level of consciousness, presence of reflexes, pupillary responses, but really you don't disturb the patient to do these things. It's important to understand that patients might speak to or about various family members or friends who have died before them. They want to give instructions to those who will survive them, and they want to talk about projects that they haven't been able to complete. So make sure that there's allowance for these sorts of things with active, careful listening. Can identify specific patterns in the patient's communication. And John Bowlby said, the loss of a loved one is one of the most intensely painful experiences any human being can suffer. Now, after the patient dies and is pronounced dead, the nurse prepares or delegates the preparation of the patient's body to CNAs, and really what they do is clean the patient up for viewing by the family. When preparing the body, you want to take cultural customs into consideration, and any agency policies and procedures or state law. Some cultures and in some kinds of deaths, it might be important to allow family members to do the preparation of the body or assist with that. Keep that in mind. When you are preparing the patient's body, you want to do a few things like close the patient's eyes, put their dentures back in their mouth, wash their body if it's necessary, remove tubes and dressings, straighten out their body, but leave a pillow in place to support their head. family should be allowed privacy and as much time as they need with the deceased person. Um, Sometimes with unexpected or unanticipated death, uh, depending on what your agency policy is and what the circumstances of the death were, you might need to leave tubes and things like that in place, especially if there's going to be an autopsy. Um, Finally, let's just remember that sometimes the nurse will have feelings as well, and it's okay to cry with the patient or family during the grieving process to show them that you feel badly as well. Um, you don't want to certainly overdo it, but I've known patients and families who, you just can't help but be touched at that time, and so it's perfectly okay to shed a tear or two with the family. And in small towns, if you knew the family or the patient outside of the hospital or setting, um, going to the funeral is perfectly acceptable.